Now we are on live.
Good evening, everyone, and welcome to today's YouTube live session on diabetic retinopathy, protecting vision in the face of diabetes. I'm Lalita, a second-year-old MBBS student, and I'm your host for today's discussion. I'm thrilled to connect with all of you. I'm elated to thank Medusane for giving me this incredible opportunity to host the session. It gives me immense pleasure to introduce Medusane, a platform that has rapidly grown to become a trusted educational partner for medical students across India. Our mission is simple to provide accessible, high quality educational resources that empower students to excel in their academic and professional journeys. With a vibrant community of over 23,000 YouTube subscribers, Medusane has made a significant impact in areas like clinical case presentations, theory lectures, MCQ discussions, career guidance, and skill development. We are constantly evolving to meet the needs of our students to help in building strong foundations in medical practice. While there are numerous platforms offering medical education, Medusane uniquely emphasizes personalized mentorship, which aims to provide students with daily guidance, one on one support, and practical insights that go beyond textbooks, helping them build confidence and clarity in their career paths. As World Diabetes Day is being celebrated on 14th of November every year, we are reminded of the importance of awareness, education, and collective effort in combating one of the world's most pressing health challenges, diabetes. This year, we are excited to present a special lecture series dedicated to deepening our understanding of diabetes from its physiological and biochemical foundation to its management and complications. World Diabetes Day is more than a date on the calendar. It's a global call to action. Diabetes affects millions of lives, impacting not only patients but families and communities. Through this series, our goal is to bring together experts in the field to share valuable insights that empower healthcare professionals, students, and the broader communities to tackle diabetes more effectively in their daily practice. Each session is designed to address crucial topics from the basics of insulin function to advanced management strategies, along with latest guidelines. This initiative emphasizes the role of continuous learning and collaboration in addressing diabetes and aims to equip you with practical knowledge and skills that are essential for improving patient care. We believe that raising awareness and fostering understanding of diabetes is vital in reducing its burden on society. We are grateful to our distinguished speakers and enthusiastic participants for being part of this mission. Together, let's make this World Diabetes Day a step forward in our journey to a healthier, diabetic aware world. Today, we are on session 6 and we are shining a light on a critical complication of diabetes, that is, diabetic retinopathy. This condition affects millions globally, and early detection is crucial for preserving vision. Diabetic retinopathy is a silent thief, stealing vision from those affected and often without warning signs. It's a complication that can lead to blindness, impacting not only individuals but families, communities, and societies. Imagine waking up one morning unable to see the faces of loved ones or read the word on a page. Imagine the fear, uncertainty, and loss of independence. But there's a hope. With early detection, timely treatment, and proper care, we can prevent vision loss and restore hope. We are joined today by Dr. Niranjan Karthik Sir, Junior Consultant Ophthalmologist, Nirmal's Eye Hospital, Tambaram, Chennai, who will share his valuable expertise. Sir has did MBBS at Kasturba Medical College, Manipal, and Sir has got Best Outgoing Student of the batch. Sir is a TMA Pi Gold Medalist. Sir did his ophthalmology in MMC Chennai. Sir is a lifetime member of Tambaram Ophthalmic Society, IMA Tambaram, Tamil Nadu Ophthalmic Association. I would like to call upon Raghunandan Sir, founder and chairman of Medusane, to welcome the guest of today's lecture.
Good evening, everyone.
On behalf of the team Medusane, I would like to extend a warm welcome to everyone to the today's session on World Diabetes Day lecture series. I think today we are on the day 6 of Diabetes Day lecture series, which we started on 12th. And it's our privilege to have Dr. Niranjan Karthik sir with us today, one of the fantastic academician as well as one of the mentor of ophthalmology in our lecture, in our YouTube channel also. So I welcome you, sir. It is wonderful to see such enthusiastic participation from our students' side as we continue our journey to explore the different dimensions of diabetes care and management. In today's session titled Diabetic Retinopathy, Protecting Vision in the Face of Diabetes, we will focus upon the relationship between the diabetes and the eye health. With this profound knowledge and practical insight, Dr. Karthik sir will guide us on how to detect, manage, and mitigate the risk of diabetic retinopathy, ensuring a quality of life for those who are affected. I'm very grateful for your presence, sir, and thank you for encouraging us to actively do these sessions. Without the faculty's support, it's definitely a difficult job for us. And thanks to the team Medusane for organizing this. Now I think the session is yours, sir. Kindly go with your session, sir.
Thank you, Dr. Raghu. So at the outset, I would like to congratulate Medusane for taking up this wonderful initiative on the occasion of World Diabetes Day and having such an eager audience to, attend the series of lectures that is themed on this wonderful concept of World Diabetes Day. And uh, and thank you so much for the kind introduction as well from Dr. Lalita to be Dr. Lalita and Dr. Raghu. So without further ado, let's get to the heart of today's purpose, why we've all gathered here virtually. And just how the topic was introduced as silent thief of vision, I would like to rephrase it and call it the violent thief of sight. Now, why would I call it violent is because more than just, having a very narrow, the so-called tunnel vision we see in glaucoma, just like, focusing just on diabetic retinopathy. Instead of that, we take a back seat and let us today sit back and see how diabetes can affect the eye as a whole. And as we were being introduced just by Dr. Raghu, diabetes and eye health, I think, should be given more of an importance and emphasis rather than just speaking about diabetic retinopathy. And I'm here today to try to look at this thing as a blanket or an umbrella perspective. Okay. So without any delay, let's move ahead. So firstly, what is the agenda for today? Now I'm going to have a brief discussion on, or I would say a talk on spectrum of diabetic eye problems as a whole. Because diabetes is one sinister thing that doesn't spare any part of the eye, and we will see how, how it affects each and every portion of the eye. And then comes the elephant in the room, the diabetic retinopathy, which is always a thread that looms over every single diabetic across the world. And like what Ms. Lalita had mentioned, it is not even an exaggeration to say that one fine day you wake up in the morning and suddenly some of them, which were, I would say, quite lucky enough to detect it, realize that they're not able to see what they could see the previous night. And that could be as cinematic and drastic, dramatic kind of a presentation that anybody could have if they fail to take care of the diabetic control. And lastly, we'll see what can be done at all, in two different perspectives. One is the preventive and the second is the corrective measures in order to try to at least control the complications and the dire consequences of this crucial disease of diabetes. Okay, from the eyes perspective. So we've had wonderful lectures so far in this series, which has emphasized more than enough about the burden of the disease. So it is the second, country to be affected by diabetes in the entire world, and prevalence of diabetes in India. In fact, for some reason, some states which are quite advanced, even in healthcare, still suffers to a great extent from this burden of diabetes. So as you can see here, it varies widely from 5% all the way up to 15 to 16%. And this high prevalence is so much so that 1 in every 10 adults are observed to have diabetes in India in certain states, and Tamil Nadu is no exception. So there have been several population-based studies and surveys in India over the past 2 decades. And we have a very interesting trend, which is not very similar to what we see in the Western countries. A significant portion of this diabetes continues to trouble the rural population in India, which has very minimal access to healthcare even till date. And we'll be seeing what this diabetes does to the eye. And when you look at it, it is actually quite disheartening to see that a large portion of them fail to even detect it at a stage where almost nothing can be done. So it is that kind of a scenario that we face, and added to it is the minimal access to healthcare, which makes matters worse. So let us talk about the broad spectrum of eye diseases that is encompassed in diabetes. So let's have a very systematic approach going all the way from front to back, and we'll be covering like I said, the monster diabetes retinopathy at the end. So first is the lids and adnexa. Now we have to look at it, and I have tried to theme this entire presentation as to what a general practitioner would want to know and would like to be touched upon from a diabetes and the eye perspective. So starting from the anterior most aspect, which is even outside the eyeball, that is the lid and adnexa, diabetes does not even spare that. Recurrent stye and chalazion. Okay, so what happens is the body as a whole has a predisposition to get infected and remain infected for a longer period of time compared to non-diabetic, right? So when a patient, this is something which is quite common and at the same time very much missed in many of our practice sessions. So what happens is a patient often presents with stye, and he must be or likely be a person who works on the system for quite some time, and we always attribute these sort of situations to dry eye syndrome. But often it is very important to not miss a recurrent stye. Okay, a person is being treated, was on treatment, was quite compliant with medications, and still ended up having this one yet again. And second part of it is very crucial. When they present in a very exaggerated, sort of a clinical scenario with a large stye and multiple styes, at the same time in a single lid, or both eyes being, affected simultaneously. These are all red flag signs that you must immediately evaluate them for the presence of diabetes. And blepharitis is more often than not overlooked in many of them because they present to you with itching. And itching is probably the most common symptom with blepharitis. But blepharitis again can be an infective etiology, most commonly by Staphylococcus. So again, if you see, the underlying root cause remains to be infection, but why does it happen again and again is what is not picked up by many people. Now let's move on to the ocular surface. Now, when you talk about ocular surface and dry eye constitutes the major chunk of what can happen to the ocular surface in diabetes. And the most probable mechanism responsible for dry eye in diabetes is extensive hyperglycemia, bringing about corneal neuropathy. So we've had enough, discussion or knowledge being imparted to us talking about mononeuropathies in diabetes, right? So nerves are not spared in diabetes, and so is the corneal nerve. And corneal neuropathy leads to tear film instability. Remember that the tear film production is itself based on the corneal reflex. Once that afferent gets impaired, it's going to not signal the eye to produce enough tears. And hence you have parameters like TBUT, which is tear film breakup time. And that value tends to drop down due to loss of conjunctival goblet cells. So all of this put together presents as a dry eye, even in patients who do not have enough system exposure. Now, that is again a big sign or an indicator saying that you need to screen them for diabetes. Now, a person, let us say, is a coolie by profession who lifts so many kgs of weight every day. He is not going to spend so much time in front of a screen. But still they can have this dry eye, and that could be because he has not been screened for diabetes, and he must be a middle-aged man working for so many years in this field, and he's not been taking care of his body enough, right? So one more, again, the very concept of recurrent infection again applies here as well. A case of recurrent conjunctivitis not responding to the usual set of empirical treatment medications again should ring a bell in your head saying that the person could have diabetes, and it is very crucial to screen them even if they do not have other symptoms of diabetes also. So we have had ample examples in our practice where we have detected diabetes only after they presented to us with recurrent symptoms like stye, chalazion, etc. And the patients themselves have been, completely shocked. They had come for something else, and we ended up diagnosing something else for them. But yes, it is indeed a very surprising factor at many cases of these sorts. So it's important for us to know that conjunctivitis is something very common, can happen to anybody, but this not resolving with proper treatment and persisting for weeks together or having recurrence in spite of having completed the proper due course of medicines should ring a bell of diabetes. And this is not so common yet should not be neglected manifestation of diabetes, which is diabetic keratopathy. Now, it all stems down to the fact that corneal nerves are not working properly. So even the smallest of the foreign bodies or the particles, dust or anything that falls onto the eye of the patient can induce enough damage and lead to trauma, which is not so obvious simply because the patient is not able to appreciate the kind of pain. So several pathophysiological abnormalities have been shown. One of them is an abnormally thickened and discontinuous basement membrane. Now, what does this mean? Remember, basement membrane anywhere in the body is the cementing material that keeps the overlying epithelial cells attached to it. Once this is not proper in either structure or function, it is definitely going to hamper the function or the integrity of the epithelial cells that overlie them. And hence, that leads to epithelial fragility, decreased epithelial healing rates, and increased sorbitol concentrations, which again is following poor glycemic control, can further worsen the situation. So this is about the cornea. Let's get a little deeper into the eye. Now, when you talk about cataract and diabetes, we all have this fancy question coming up in MCQs, and we anticipate it in NEET as well, right? The typical snowflake cataract. Yes, that is sort of typical to diabetes, but what is more important for us as ophthalmologists in routine practice is that diabetes itself has a multifactorial implication in cataract. Now, what do I mean by that? Let us say a patient is diabetic and they present to us. A couple of things we do or we should not miss out on. First, they present, let's say, in an early phase of cataract maturity, maybe nuclear sclerosis grade 2 or so. And more often than not, when you tell them that they need to get operated, the first question they ask you, doctor, how long can I wait before I can proceed with surgery, or how long can I postpone the surgery for? Now, one important thing in cataract counseling for such patients would be to inform them that diabetes is one factor which can cause rapid progression, especially if uncontrolled, in progression of cataract. Now, this is important because from even a medico-legal perspective, it is important to let them know that they are at an increased risk compared to anybody else that they would probably compare themselves with for progression of diabetes. Now, secondly, when you talk about the types of cataract, we know there are multiple, starting from senile, nuclear, senile cortical, etc. But there is one particular type of posterior subcapsular cataract, which is very common in diabetes, and it often makes it quite sticky because the kind of deposition of sorbitol inside the lens, which distorts the arrangement of the lamellar structure inside the crystalline lens fibers, that is very, very notorious to make it quite sticky, can make the surgery quite more difficult while we do phacoemulsification in order to absorb the cataractous lens. Secondly, what they have identified is more than finding a single type of cataract, let us say senile nuclear or senile cortical, diabetes, not only does it affect the entire eye as a whole, even within the lens, it fails not to, it does not fail to affect every part of the crystalline lens, be it the nucleus, be it the cortex. So more often than not, we end up finding it to be a mixed type rather than a mono type of a cataract. Now, why again is this useful? Because you be more prepared as an ophthalmic surgeon to be able to deal with the different parts of the cataract. Let us say there is a capsular cataract. You got to be more careful about the posterior capsular rent. Now, let us say there is a nuclear cataract and we just spoke about a subcapsular. Now, let us say it's a nuclear cataract. You need to provide higher phaco energy in order to be able to emulsify that. Now, do you understand that just knowing about the snowflake cataract does not serve the entire purpose for an ophthalmologist? Even the usual senile cataract has a very different morphology when you talk about it in a diabetic compared to what you see it in a non-diabetic person. So after that comes glaucoma. Now, glaucoma per se is basically damage to the optic nerve, secondary to a raise in the intraocular pressure. Now, when you talk about the types of glaucoma, again, there are multiple. Now, what is most relevant or important from a diabetic perspective is that it is a major etiological factor for neovascular glaucoma. Now, we will be discussing in detail about diabetic retinopathy, where we will be talking about neovascular glaucoma as one of the complications. Neovascular glaucoma, the first thing you think about in an elderly male or female presenting to you is whether they're diabetic, because that is, being the diabetic capital of the world, it is definitely important for us to rule that out first before thinking about any other possible cause of neovascular glaucoma. What is neovascular glaucoma? Basically, there is proliferation of new vessels, neovascular, that leads to damage to the anterior chamber angle in several ways. One is fibrosis, one is growth of new vessels, etc., leading to poor drainage of aqueous humor. Now, let's keep it simple at that level. But what is most important is, yes, this is the most notorious type of glaucoma that we should be worried about for our diabetic. Coming to the other more commonly seen forms of glaucoma, where will you suspect diabetes, or what relation does diabetes have to that? Now, that is where you need to understand the two most common types. That is the open angle and the angle closure. That is the OAG, open angle glaucoma, and the angle closure glaucoma. Now, there is some amount of attribution in the open angle where the progression, again, just like we saw in cataract, the progression in glaucoma in cases of even primary open angle, if the patient is diabetic, is that there is poor blood supply following microvasculopathy in diabetes, which is very commonly seen. Now, even diabetic retinopathy is a microvascular complication of diabetes. Am I right? So, similarly, the blood supply to the optic nerve is very poor and erratic, which adds to the optic nerve damage that is caused by the pressure that is raised inside the eye. So, it is a dual damage that can cause for faster progression in glaucoma in patients with diabetes. I'm talking about open angle glaucoma. Now, diabetes is also said to be associated with angle closure, not so much, but it is believed that the patients end up having a bulge in the crystalline lens, and that bulge is sent to occupy a lot more space than a normal lens in the anterior chamber, thereby narrowing the angle and decreasing the exit of aqueous humor. Now, at this particular point, I would also like to touch upon another very interesting and a very commonly seen phenomenon in our routine practice, which is very much missed. As I told you, we have a very established pathway of sorbitol pathway, which is implied or which is sort of implicated in the pathogenesis of cataract formation, right? So what it does is the sorbitol enters the crystalline lens but does not get reverted out because of the lack of enzyme sorbitol dehydrogenase, right? So we've touched upon this topic in detail in biochem. Now, what is important here is that once it enters the lens, that is a crystalline lens, because sorbitol is hygroscopic, okay, it has a tendency to attract water. It tends to attract water and the lens swells up. Now, this happens when the patient is having a poor glycemic control. So what does the patient experience? Because there is an increase in the bulge or the increase in the convexity of the lens becomes more convex, has more converging power, and the patient will end up becoming more myopic. So there will be a temporary shift in the refractive error status of the patient, and the patient will have experience of blurring. Now, if the patient presents to you and you fail to elicit the history of uncontrolled diabetes, you end up prescribing this erratic or the erroneous refractive error to the patient. They will end up having reversion back to their original power or even no power after their glycemic control is achieved. And then they walk back to your OPD and then they start complaining, saying that the power of the glasses that you have given is wrong. So it is very, very crucial to ask a diabetic whether their sugar status is under control. And in fact, we even postpone the prescription of glasses to a later date after the achievement of glycemic control in patients who are not having good glycemic status. So this is something that I want all of you to know, because jumping to prescribe glasses in a diabetic can be disastrous even for the patient as well as for your own practice. Now, a less commonly known problem is the diabetic papillopathy. What is papilla? Papilla is the Latin word referring to the optic disc. It's an uncommon ocular manifestation and can be a very fancy MCQ question for, or an image-based question, simply because it is something that mimics papilledema. Okay, or I would say papillitis or the optic neuritis also. Important point, what I wanted to mention here is diabetic papillopathy is mostly unilateral, can be bilateral also. So, and it should be kept in mind as a differential for a more sinister or a more disastrous differential diagnosis like optic neuritis or papilledema, simply because in a in a diabetic patient, if they present to you with this kind of a fundus picture on presentation and they complain nothing about visual difficulties, it cannot be optic neuritis, because optic neuritis will present with diminution of vision. Or either it can be papilledema or diabetic papillopathy, and always remember papilledema is bilateral. So it is mostly very inconspicuous, or I would say less dangerous alternative or a differential for papilledema in a diabetic, and you have to think about diabetic papillopathy as a differential. Is that clear? They do not have visual dysfunction like you would expect in optic neuritis. Remember, even in papilledema, patients do not complain of visual complaints like blurring of vision or something. They can have headaches. But even if the patient is not having headache and is a diabetic with this kind of a picture, do remember diabetic papillopathy as well. And finally, we are here, I think, to what we were planning to discuss today as a topic of discussion. So before this, what I wanted to deliver or convey is that diabetes is not always just diabetic retinopathy as far as the eye goes. So it is beyond that, and many of the things beyond that is actually what is often missed in our routine practice, and that's what I wanted to highlight before we jump to the major topic. So let's get to the major topic of today, that is diabetic retinopathy. Now, diabetic retinopathy from time immemorial has been studied and studied and is still being studied. So it is that vast because not only because the disease is quite complex, it's also because the disease burden is enormous. And the diabetic retinopathy is so special to the medical fraternity because it involves a multidisciplinary approach. Okay, so there is a lot of correlation between what happens in the eye to the rest of the body. And diabetic retinopathy is one such disease which gives you a fair idea as to what is going on with diabetes in the person by simply getting to see into his fundus rather than having to subject him to a multitude of tests. So here, what I wanted to stress upon is that after 20 years of diabetes, 99% of the patients with type 1 and 60% of the patients with type 2 show some degree of retinopathy. So it is something like when you talk about cataract as a part of aging, diabetic retinopathy now has become a part of diabetes without having to mention about it separately. Now, good glycemic control is the most important factor in the medical management of DR, which again is what I wanted to emphasize is that most of the management is not uh, under the purview of ophthalmologists per se. Now, we will be discussing in management as to where we come into the picture. So, glycemic control often does the majority of the job for us for keeping this under control and, in fact, preventing it as well. Now, there is this very famous study which talks about the role of co-role or the symbiotic or the synergistic role of hypertension in facilitating or aiding the progression of retinopathy, and that is the UKPDS study. So these are some of the studies which have been landmark in trying to understand this disease of diabetic retinopathy. Now, who is at danger? Now, when you talk about a person with diabetes, you don't jump to brand them that okay, this person will have diabetic retinopathy. That's not how it works. You need to be very considering the massive population of a country and the disease burden affecting such huge numbers. It is very important for us to have a high index of suspicion in order to be able to use the limited resources we have at hand and provide the maximum benefit to the masses. So that is where this question of who is at danger, in spite of being diabetic, what are all the factors you should probably look out for in them? And in order to subject them to the process of screening, which is actually quite demanding in resources perspective. So, who is at risk of developing diabetic retinopathy? The most important factor is the duration. Okay, the longer they have been diabetic, the more is the risk of developing diabetic retinopathy. And second is poor control of diabetes. Pregnancy, we know, is a state where everything keeps fluctuating. You talk about blood pressure, you talk about sugars. Now, I would say the duration being the most common factor, the fluctuation in sugars again has a lot of implications in bringing about acute manifestations in diabetes. So that is where pregnancy comes into picture. And there is a completely, separate entity of GDM which can come into a picture and make the patient diabetic for the rest of their lives as well. Now, to add to this complicated aspect of diabetes, if there is a concurrent comorbidity like hypertension, nephropathy, hyperlipidemia, and habits like smoking. So these are all the factors which definitely suggests that the patient is at a much higher risk compared to another diabetic who does not have these risk factors. So these are the kind of people you would want to subject to the rigmarole of getting screened for diabetes, which is not too complicated, but at the same time, it is pretty time consuming both for the patient as well as the ophthalmologist. So what is more important is by screening these people, there is a very good chance that you can reduce the microvascular complications that can possibly happen in them in the near future. And see, like I had mentioned, coming to the duration of diabetes, more than 10% decrease in HbA1c drastically drops your risk of getting diabetic retinopathy by 40%, which is a huge number. And that again goes to show that the chronic control of diabetes is more important than having controlled your FBS or PPBS on the day of examination, because this is very important, dear all, because the day they present to you in your OPD, the bare minimum you ask is, how is your glycemic control? And then they come out with pride and they tell you, doctor, today morning I checked my FBS, it was only 70, and then PPBS was only 120 and 140. And, and then you're like, wow, this person must be having a very good control of his glycemic status. But that is where we fall wrong. It is important to know what has been happening to them over the past few months, if not few years, in order to be able to tell them that, and it is very important to convince them more than you being convinced, because patients believe that once you bring the sugars under control, everything that has happened to them in the past because of that should revert back. And that is not how it works. So what is the exact problem in this entire disease process? So hyperglycemia is one factor, along with the state of being, in a state of inflammation all the time. Is we would have come across in pathology where we say that it is an inflammatory state. The diabetes per se is a chronic inflammatory state. Both of them put together results in local hypoxia. Now, how does it happen is simply because there is damage to vessels. And whenever there is damage to vessels, the blood supply to that part of the body, whichever it may be, including the retina, is suffering from hypoxia because of lack of adequate delivery of oxygen. Now, when that happens, body, just like a beautiful machine it is, always has some compensatory mechanism, not bothering whether it's good or bad for the body. Like just we have autoimmunity and allergies, though it is an immune response, being exaggerated is what is the problem. So similarly here, elevated levels of this VEGF, and this is the main culprit in the whole story. So vascular endothelial growth factor and many more are quite elevated. And what does this do? It does three main things, which is causing all sorts of problems. One is angiogenesis. Now, when you talk about the new vessels coming into picture, you must be happy, right? I mean, there are damaged vessels following diabetes, and something is being done to construct new vessels. But the problem is these new vessels are not good enough. They are not the vessels that were actually naturally there, but they are much more frail and much more much weaker, and they are not capable of handling the kind of blood volumes and pressures that is flowing through the retinal vessels. Secondly, not only are they fragile and they can give way, by inherent nature, they have higher permeability compared to a normal vessel, which does not leak that much. And not only that, VEGF also acts on the pre-existing natural vessels and increases the gaps between the endothelial cells, and that itself makes them much more leaky than in a healthier state. And lastly, vascular damage. All of them put together does only a couple of things, and that is enough to create the whole problem. One is the blood leaks, the second is the fluid leaks. In fact, it's the other way around. The first, the fluid or without the RBCs can just leak out of the vessel, and beyond a certain stage of severity, the RBCs also come out of this gap. So when only the fluid leaks, you call it edema. When the blood leaks, it is hemorrhage. Now, where it happens, how it happens, determines visual loss. So this is what I've been trying to tell you, that the pericytes are the supporting cells, and those are the cells which get damaged when you talk about, so here, these are the pericytes, which are the supporting cells which keep the endothelial cells together. And when there is vessel damage following microvasculopathy in diabetes, there is increased membrane thickness of the basement membrane. All of these factors will make this entire vessel weak and allow for the leakage of either plasma or the fluid, as well as the red blood cells, right? So what can we do? What is our role in this whole process? We're just trying to change the natural course of disease here, trying to intercept it at the point we come in, contact, or we come in interception with the disease process. So first is to be able to see what's going on. And to be able to do that, we have several equipments. And the most common one that can be employed by anybody and everybody is a direct ophthalmoscope. So a direct ophthalmoscopic examination is way more than enough just to deem and label a person to have diabetic retinopathy or not. And it is handy, it is pocket sized, and you can carry it in the even in the water bottle pouch of your bags, and it is that handy, and it comes with rechargeable batteries and whatnot, making it so simple to detect diabetic retinopathy. Now, I wanted to emphasize the fact that it is not just an ophthalmologist's cup of tea. It is definitely something that even a MBBS student is capable of identifying with a minimal amount of practice. Then comes more sophisticated methods like fundus camera, etc., etc., etc. Now, what are the stages of diabetic retinopathy? Now, this is the most commonly followed terminologies, and so without having to get into the depths of it, I'll just keep it as simple as possible. Whether new vessels have come in or not basically divides the entire spectrum of diabetic retinopathy into two broad categories, because the perspective of treating itself differs. Okay, as practitioners, we are more concerned about the practical ways of classifying things rather than just knowing it for theory, right? So once the blood vessels, the new vessels come in, the perspective of treatment changes and it becomes proliferative diabetic retinopathy. What is proliferating? New vessels are proliferating. Now, when there is no such new vessel on examination, then it is a non-proliferative diabetic retinopathy, which is an earlier stage to PDR, that is proliferative diabetic retinopathy. Now, you don't have to get into the details of this, detailed classification, but this is very, very commonly used in our routine ophthalmic practice. It's more of a remembering thing rather than anything, but I'll try to touch upon a few concepts here. Now, as I told you, the crux is new vessels or no new vessels. Once you do not have new vessels, you still have to grade it in order to adjudge two things. One is whether there is a risk of this patient having visual loss at that stage itself. Second is whether this patient has a risk of progressing to proliferative stage of diabetic retinopathy, right? These are the two main things or the reasons why you would want to grade this non-proliferative stage. Otherwise, non-proliferative stage is more often than not taken care of by the diabetologists and the general medicine experts by trying to achieve good glycemic control and nothing more. Okay, so I will also touch upon the screening protocols and the referrals. But before that, just know that there are 4 different stages: mild, moderate, severe, and very severe, based on the number and the type of findings you see in the fundus. Okay, I'll run through a gallery of images that I have to show you for the different findings. Okay, once it has new vessels, it enters the domain of proliferative diabetic retinopathy, and the amount to which these new vessels have conquered the retina decides whether it is early PDR or high-risk PDR. Now, early PDR or high-risk PDR depends on where these new vessels are and to what extent or the size have they occupied the retina. Okay, so I'll show you with some pictures. See here. So this is what I was telling you. When you talk about non-proliferative, even as you can see in this image, there is a lot of blood and yellowish things. I'll tell you what they are in the upcoming slides. But there is no new vessel per se. Okay. On the other hand, here, what you're seeing is actually not the routine blood vessel, but it is actually a new vessel that is proliferated out of the pre-existing natural vessels, right? So, once we touch upon what happens in the retina as a whole, we are really, really bothered about the center of the retina, which is the macula. So this part is macula, and this is the normal fundus. Okay. Why are we so bothered about macula is because 70 to 80% of what we see in routine practice, what we see in routine life is just the central vision. And macula is the most important part of the retina for central vision. And anything that is going to even slightly disturb the macula is going to have severe manifestations in vision in the form of vision loss or altered shapes and sizes, which we call as metamorphopsia, etc., etc. And in fact, for all of you to know, this is actually the stage when patients end up presenting to us at all if they present. Because before this, if the macula is not involved, then the patients do not have symptoms or they fail to appreciate the symptoms and they do not present to us. So at this stage, once their vision is being affected to whatever extent is when they present to us for management. Now, when you talk about the stages and how do you correlate with the previous staging system that we saw, it is important for us to know that mild diabetic retinopathy mild NPDR often does not affect the macula. Only in the stage of moderate diabetic or the moderate NPDR, do you see a coexisting diabetic maculopathy, and any stage after that is expected to have diabetic macular edema, and if it doesn't, it is highly unusual. Okay, so why am I saying this is because picking up diabetic macular edema on such frank fundus presentations is quite easy, but sometimes it demands to be detected using some investigation, which we will see at an earlier stage, and the treatment can give really good results. So when you see moderate NPDR and still do not have too much of a suspicion of macular edema, it is important for you to get an OCT done to rule it out before reassuring the patient that glycemic control is alone sufficient. So that is what I say when I talk about diabetic maculopathy. So before the days of OCT or availability of investigation, even till date, OCT is not accessible to all parts of the country or all parts of even the state. So there are proven or established ways to deem a person needing treatment for the macular disease, okay, or not, simply by clinical examination. Okay, so that is what is called as clinically significant macular edema, or CSME. Now remember, CSME to be established as a diagnosis does not need ancillary investigations like OCT. So all it says is whether there is thickening or edema of one disc diameter or larger. Okay, that is what this is the criteria. Okay, so whenever there is any edema which is one disc area or larger, okay, from the center of the retina. Okay, so this is the center of the retina, in fact, center of the macula. Okay, this is one disc diameter radius. If it is that size or larger, okay, then it is clinically significant macular edema. That is the first criteria. Okay, in this very area, okay, this is actually one disc diameter is 500 microns. Okay, now what is this line or wavy circle trying to convey to us? Now, if the diabetic macular edema is not exactly in the center and it is slightly eccentric, then when will you call it CSME? Okay, you will call it CSME if it is more than one disc diameter, okay, of radius, any part of which, okay, if it is lying in the central part. Now, this is slightly tricky, but I would repeat it. If the diabetic edema or the edema is big, but it's eccentric, it is big meaning more than one disc diameter, okay, and if any portion of this comes within this perimeter of one disc diameter from the center, again, it is clinically significant macular edema. Now, why do we have to bother so much about this? In days when OCT was not available, or even in till date in camp settings where OCT access is still not available, you just have to establish this and proceed with treatment for macular edema. It is that determinative or that powerful, I would say, to give you clearance to treat the patient for diabetic macular edema, and hence knowing this criteria is crucial. So when you don't have to bother too much about the non-availability of OCT, that is again the gold standard today to establish diabetic macular edema. And what you see on the right side is actually accumulation of fluid, and there are several morphologies, cystic, spongy, etc., etc., etc. But what you need to know is that retina is now being split into layers, and there is collection of fluid between the bottommost layer, that is the RPE, and the remaining layers of the retina. Okay. Now, this is the crucial part. STDR. Now, STDR is not a part of the classification we discussed before, which is actually ETDRS classification and used worldwide. This is a new emerging concept of sight-threatening diabetic retinopathy, meaning whatever affects vision concerns us, right? So anything that is going to hamper the vision comes under the umbrella term of sight-threatening diabetic retinopathy. And diabetic macular edema, like I mentioned, does that, and so does proliferative diabetic retinopathy. So what is this PDR? What so if new vessels are going to proliferate? What is the big deal? See, the moment you have new vessels and they're going to leak, they can, if they are around in and around macular region, they end up accumulating a lot of fluid in the central portion, that is the fovea and the macula. While if they are in the periphery or even in from the macula or around the disc, okay. Now, when you say NVD, it is neovascularization of disc. NVE is neovascularization elsewhere. As you can see here, you can see a lot of fine, thin vessels. Can you make it out? Okay, they're not the usual ones, right? Usual one, you see 4 vessels branching out and maximum a couple of thick vessels. But you can see these fine, lacy vessels here. These are neovascularization of disc, new vessels on the disc. And the moment they bleed, they result in what we call as vitreous hemorrhage. What does it do? This is exactly what Ms. Lalita was mentioning, right? One fine morning you wake up, one person wakes up and then they're not able to see through their eyes because these vessels might have bled either later in the night or early in the morning. And why am I saying early in the morning is because that is when cortisol spikes up for all of us around 3 to 4 a.m. in the morning. And cortisol spiking up will lead an increase in the blood pressure. And these vessels are too frail to be able to handle and contain the blood pressure. They break. And that results in vitreous hemorrhage. So vitreous hemorrhage, once it sets in, can be really, really vision compromising. And not only that, it is not an easy job to be able to clear that. See this? So these are the new vessels which have bled. And you can see the thick, dense layer of bleeding all over the central portion of the retina. And this patient would hardly have, I would say, counting fingers or maybe 160. That is the kind of vision he is expected to have. Now we are going to touch upon another interesting investigation, which is known as the fundus fluorescein angiography. Now, new vessels are so thin, so frail, and it is not very easy to be able to detect them with naked eye or even with sophisticated high definition fundus cameras. Those are available now, but a few years before, it was not the case. So there is this investigation where you inject the dye through the antecubital vein, and this dye goes and lights up the entire retinal vasculature, as you can see here. And you can see that there are many blotches of this dye getting, stained all over the place. This is very simple logic. You inject the dye goes in mixed up with the blood, and this mixed dye exits out along with the blood into the spaces where there is fluid, not just blood, even fluid. That's what I wanted to highlight. Blood could be even picked up with naked eye, right? But these new vessels, before they could leak out blood, they can still leak out fluid. And to be able to pick them up at that stage, FFA can be very, very useful, right? And lastly, once this separation between the retina and the underlying RPE I was telling you about, right? At the macula, it is quite disastrous for vision. Yes, indeed. But beyond a certain stage of proliferative diabetic retinopathy, a lot of hemorrhage and, okay, before that, the hemorrhage that is in the vitreous, how does it heal? Anywhere there is bleeding, it has a lot of heme, iron, etc., right? So it elicits inflammation and leads to fibrosis, okay? Now, when there is fibrosis in the vitreous cavity, it results in formation of fibrous bands that is going to run across the entire vitreous cavity. And with the movement of the eye, which happens all the time, okay, when you try to look at different parts of, when you try to look around you, these tractional bands are going to keep pulling on this layer of retina. Okay, retina is what? It is just a thin transparent layer that is stuck onto the underlying RPE and the choroid, right? So it is going to keep pulling, and the moment it pulls, it results in tractional retinal detachment. Or this pulling can lead to formation of a small hole in the retina, leading to regmatogenous retinal detachment. Regma is a break. Regma is a Latin word for break. So it can lead to retinal detachment in 2 different ways. Either it can pull the entire retina being a thick fibrous band, or it can make a hole and cause the fluid and the vitreous gel to enter into the gap and separate out the layers, right? So they have both kinds of retinal detachments possible. So we just spoke about the investigations, right? So fundus photo is the bare minimum. which helps us not only identify a problem, like I mentioned to you, sometimes all you can tell the patient is reassure and tell them to have a good glycemic control when you detect mild diabetic retinopathy, mild NPDR, right? But what happens is you need to know what was the situation at some time in the past to be able to compare it today and tell them whether there is progression, right? All we are bothered about is progression. So if there is progression or not can be only identified if we have two fundus images at different points of time. So that is possible only through fundus photo documentation. And FFA, I already mentioned to you that new vessels and leakage, and OCT is cut section through the back part of your eye, which is the retina, which helps in identifying collection of fluid. So coming to the treatment. So treatment is mostly and almost entirely going to be relying upon glycemic control. Now, imagine, or I would not say imagine, just try to understand the fact that even if you bring it under control and you try to deal with the microvascular diabetic retinopathy, there is no guarantee that it will not recur to them if again the glycemic control goes out of hand. This is the sorry state of affairs for many of our diabetic patients, and it is very, very important to counsel them that all we are doing is just damage control. We are not trying to foresee and prevent the undue complications that are likely to occur following loss of diabetic control. It is very, very important because many patients think that it is one-stop treatment. You come, you do laser, you do surgery. I'll touch upon that a little while. But they think after that they're going to be as comfortable as them. It's not their fault because that is what a cataract surgery does to you, right? So patients come to you and they get operated for cataract and that's it. They don't get cataract again. So they, by inherent nature, apply this principle even to diabetic retinopathy, and that does not work that way, right? So this is the treatment outline for diabetic retinopathy. So like I had mentioned, if you see here, I've tried to keep it limited to the role of an ophthalmologist, and you can see that the non-proliferative diabetic retinopathy mostly, it doesn't even feature in this outline. That is simply because it is more rather dependent on the general practitioner to keep the glycemic control rather than the ophthalmologist having to do much, other than just keeping a tab on how the fundus is from time to time. Okay, so once it goes beyond just NPDR into macular edema, like I had mentioned, the culprit is VEGF, and the first line of treatment nowadays is anti-VEGF injections. Now, anti-VEGF injections again are multiple. It all started with an off-label use of bevacizumab, which was called Avastin, and then there came eye-specific anti-VEGF agents like ranibizumab, and nowadays we have even more advanced ones like aflibercept. Just know these names because they are still being fancied in many of the entrance exams to be asked as MCQs. And before the era of anti-VEGF injections, there was a consideration of laser. Now, this laser was focal laser, where the laser argon laser, okay, the green laser, was being focused at the areas of leakage around the macula. Thereby, it is sealing it with heat and preventing the leakage from happening constantly. And over a period of time, eventually the fluid gets resorbed and the patient regains vision. So this was a principle of using laser before. But what happened was, you're talking about the centralmost part of the eye, right? So there is always a risk of you ultimately damaging the central fibers or the fovea, thereby resulting in visual threatening complications, right? So instead of that, once anti-VEGFs started proving their efficacy, that took over as the first line, and focal and grid lasers took a backseat. Okay, so that is the role of treatment of macular edema. Now, moving on to proliferative diabetic retinopathy, what are you trying to do? There are a lot of new vessels all over the place, right? So all you have to do is fire laser all over the periphery of the retina, okay? Not in the center, but in the periphery of the retina. And what are you doing is simply burning the live retina, and you're going to make it anoxic. Try to understand this. the retina is already hypoxic. Okay. Hypoxic meaning it is not getting enough oxygen and demanding for oxygen by secreting more VEGF. And this VEGF is a culprit for the whole pathogenesis of diabetic retinopathy. So what are you doing? You're actually killing the peripheral retina, thereby not having to make it demand oxygen and release VEGF. Now you may ask, aren't we, inducing damage, and can that not lead to, vision loss or threatening to vision? See, like I had mentioned, the most important part of our vision is actually the central 30 degrees, and affecting or firing laser in the peripheral retina only to a very severe extent can result in minimal loss of peripheral field of vision. But beyond that, it really goes a long way in preserving the central vision by both reducing the VEGF levels and macular edema, and also reduce the formation of new vessels, which can lead to vision threatening vitreous hemorrhage. Once it goes beyond the level of vitreous hemorrhage, where you will not be able to fire the laser simply because the entire media is hazy and you will not be able to see anything in the retina, that is when you have to consider surgery, which is pars plana vitrectomy. So what is PPV? Basically, you enter the eye into the posterior segment, clear off all the vitreous hemorrhage by cutting through the vitreous gel. See, remember, bleeding is not as simple as it happens outside the eye. What happens is in vitreous hemorrhage, the bleeding is suspended in the jelly-like substance of vitreous. So for it to clear out of that gel is going to take way longer than elsewhere in the body. Okay. So that is why beyond 3 months, when you allow or give it a spare time to settle out and still it does not settle, is when you go in for a PPV for a non-resolving vitreous hemorrhage, right? So apart from that, if it has progressed to the stage of tractional retinal detachment or rhegmatogenous retinal detachment, which can be identified with a B scan, right? So again, there is no point of simply waiting for the vitreous hemorrhage to clear, because even if it does clear, the vision is going to be still poor simply because the retina is detached from its original position, right? So that is again an indication for surgery. So these are all the different paradigms of treatment from the perspective of an ophthalmologist for diabetic retinopathy. Now, coming to screening, it is important to know that there is a high prevalence of undiagnosed diabetes in India. So screening cannot be restricted to known diabetics. So whom all will you screen? All diabetics on treatment, single record of RBS more than 200 milligrams per deciliter, and it is very, very important to not miss a mother who could possibly have GDM. So what does it do? What is the importance of this early detection? So the earlier you identify and intercept a person in the course of diabetic retinopathy, the more are the chances of better visual outcomes than having it later in the course. Okay. So firstly, there is reduced risk of vision loss, better outcomes, and the quality of life itself improves, because you're talking about geriatric population who are often deserted and isolated and having to be able to do their own chores and not having enough vision to achieve that. I'm not even exaggerating. People find it difficult to even do their routine activities of daily living after having suffered a vitreous hemorrhage. So it is really going a long way in providing a good quality of life. I'm talking about being able to do their own work and being independent. And not only that, see, the moment you diagnose a case of diabetic retinopathy in whatever severity, you often refer them to not only a diabetologist, but also to a nephrologist and a cardiologist, because they all fall under the spectrum of microvascular complications of diabetes. And there is a very, very close relation between the degree of damage to the retina to that of kidney. So it is more often than not that they end up having both simultaneously than they don't. So diabetic kidney disease and diabetic retinopathy are very good friends, and they always go along with each other. So some of the key fundus findings that you should not be missing are the hemorrhages, hard X-rays, and cottonwool spots. So microaneurysms are the earliest, but it's very difficult to identify them even in the experienced hands. But hemorrhages and hard X-rays, they blatantly stare at you from sitting in the fundus. So you have to pick them up and do the needful in order to, in the form of referral and, proper management. So we already discussed this staging, and the moment you see any of these hemorrhages, hard exudates, the bare minimum a general practitioner is expected to do is refer them to an ophthalmologist for further care of diabetes and diabetic retinopathy. Now, coming to proliferative diabetic retinopathy, I told you about neovascularization and the risk of retinal detachment. So these are all the stages that you are expected to at least know and make the patient understand. That is where we are very important role. More often, they do not have symptoms. Nowadays, not nowadays, in general, patients fail to present to a doctor even if they have symptoms unless they become very grave. Now, to counsel a patient to tell them to prevent the future complications of vision loss is a really Himalayan task for a general practitioner. But that is exactly the point or the touch point where you can save the patient's vision. So broadly classifiable into two groups for referral. This is a non-referable DR where you do not identify any signs of clinical diabetic retinopathy or mild diabetic retinopathy without much of macular edema. So in those cases, there is not much of a reason for you to refer them. And you can just try to control their glycemic status and keep them on follow-up. Anything beyond mild NPDR, that is moderate, with or without DME, do not bother trying to identify DME there because that is something that is necessitating the role of OCT, and the earlier you pick it up, the better the response. So some of the red flag signs: blurring of vision, floaters in vision. See, floaters again could be early manifestations of vitreous hemorrhage, right? Then this is actually what I was telling you about is metamorphopsia, right? The central vision in macular edema is affected in different ways. Not only does it blur the vision, it also causes alteration in the shape and size of objects in their vicinity, right? And here, what you're seeing is the central vision gets very hazy and the peripheral vision might still be retained in cases of diabetic retinopathy in macular edema. They have mononeuropathy, they have heart disease, kidney disease following diabetes, and again, any vessel blockage in the form of myocardial infarction or so on. It is very important for you to refer them even if you do not have much suspicion of diabetic retinopathy, right? So here are the few points: vision changes, prolonged diabetes more than 5 years, floaters, flashes, pregnancy in diabetic patients, right? Diabetic retinopathy is very preventable, very much preventable. Routine, repetitive, lifelong, expert, and complete systemic exam control of other systemic factors is really beneficial in any stage of diabetic retinopathy and should not be underestimated. It delays the onset and slows down the progression of diabetic retinopathy. Creating patient awareness goes a long way in preventing their complications and improving the quality of life. And by working together, we can help preserve vision and improve the quality of life for the diabetics. Thank you. And thank you once again for the wonderful opportunity to be here with you all. So I think that
Thank you, sir.
was quite exhaustive talk. I suppose I didn't realize that. Sorry about that.
First time. Close it fast. We have reached the end of today's enlightening session on diabetic retinopathy, and I'm honored to express our immense gratitude to everyone involved. Firstly, I would like to thank our distinguished speaker, Dr. Niranjan Karthik sir, for sharing his expertise and insights on this critical topic. Your presentation had led light on complexities of diabetic retinopathy, its effects on vision, and the importance of controlling diabetes. To our organizers, mainly Leander Sam sir, for organizing the tech today, and all our medicine organizers, thank you for your tireless efforts in putting together for this informative and engaging program. Your dedication to raising awareness about diabetes is truly commendable. As we conclude the session, let's carry forward the knowledge and momentum gained today. Thank you all for joining us today. Until next time, stay healthy, stay informed, and seeing the world clearly.
Thank you, sir. Thank you so much, sir. It was really a wonderful session, sir.
Thank you, Dr. Raghu. Have a good night. Take care.
Session end பண்ணியாச்சு சார். நல்ல 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 ரெஸ்பான்ஸ் சார். லைக்